Thank you. Good morning. It's great to see so many people here, and I'm just going to start off by gently introducing the mental health domain within MAHSC. It's really important to remember that there is no health without mental health, and we've had some statistics this morning already, and it's really easy for me to say that 1 in 4 people in this room will suffer from a mental health problem before the end of their life cycle. No doubt people in this room know or have experienced family, friends, loved ones with mental health problems. And that's why it's really important that we tackle this together. And I think that's one of the really unique contributions that MAHSC enables us to do that. And working really closely with research. Because in many ways, mental health has a bit of catching up to do with some of the research, say, around cancer. But I really am pleased to say that we are beginning to really spur ahead and develop. We wanted to spend this morning talking about patient care and service user focus, so we're going to go on to a specific area that's service user driven. But let's just first of all have a look at the mental health domain. I'm the domain lead for the mental health aspect of MAHSC, and my organisation, Manchester Mental Health and Social Care, is the largest research contributor of a league table of the 54 mental health trusts in the country. And I think that's something that we should celebrate and something that we don't often say. So well done, Manchester. We are very closely aligned to the Institute of Brain and Behaviour Mental Health, which is the second largest research group in the UK, and specifically around translation of research. And as a clinician by background, that's something that really, really interests me. It's how do we translate this research that we're doing into everyday practice and really start to begin to make a difference in people's lives. You can see on the screen the leans for the domain, and we've really chosen 3 key areas, because for me it is about making a difference and saying at the end of this, how have we proven that MAHSC has really enabled us to change people's lives? So we're concentrating a lot on safety. That's because we've got a really national focus of safety with Naf Kapoor and his team in the university and via MAHSC. Dementia, we have the National Clinical Director for Dementia within our organisation, Alistair Burns. And connected health, and that's what we want to concentrate a little bit on today. Before I pass over to Professor Shon, I just wanted to add one thing. We've heard today about the mortality and the really poor statistics of the Manchester population in relationship to life expectancy. If you knock 20 years off that, you've got the life expectancy of a mental health sufferer, and specifically somebody with psychosis or schizophrenia. So as we go through the next presentation, just remember the really poor outcomes that we've been looking at this morning, and then add 20 years to that in the wrong direction. And that's why we all have a duty to make mental health everybody's business.
Thanks, Michelle. And my name's Shon Lewis. I'm the academic lead for the mental health domain. So Michelle is Chief Executive of the Mental Health and Social Care Trust. And I'm just going to spend a few minutes outlining a couple of examples of what we're doing, particularly around connected health, mHealth. We do this because we're linked into the population health domain, one of the strengths of which is informatics. So we're doing a lot around connected health, particularly using mHealth and telehealth interventions. Just to remind you, so Michelle was saying that we've heard a lot this morning from Mark and others about the impact of being in Manchester on one's physical health generally. Things are just as bad with mental health. We have the highest suicide rates in the country, the highest alcohol dependency rates in the country. And as Michelle was saying, if you add all that up together and factor in the issue that people with schizophrenia and psychosis have a reduced life expectancy compared to the normal population of 15 to 20 years, you've got a sort of perfect storm, really. So the reason for that limited life expectancy is not so much through suicide, but it's through cardiovascular disease, metabolic disease, secondary to poor lifestyle issues, diet, smoking, medication and side effects. So there's a lot to be tackled. And luckily, we're a pretty big interdisciplinary research group, and as Michelle pointed out, we've focused on dementia safety. So Lewis Appleby, one of our professors, was the National Director for Mental Health until recently. He runs the confidential inquiry, the National Confidential Inquiry for Suicide, and mHealth. So I'm just going to give you a little example of what we're doing. And schizophrenia and psychosis affects 1 in 100 people. Remember that about 20% of the NHS budget goes on mental health issues. Mental health care delivery is divided between primary care, which does most of the heavy lifting, and secondary care, which, as Michelle pointed out, is a sort of parallel universe of mental health trusts. There are 54 in the country. We're the top in terms of our research into patient benefit measures. And the why schizophrenia and psychosis is so expensive is not because it's fatal, like cancer. It's 5 times more expensive than cancer. It's because it has an onset, tragically, in early adult life, and most people, 80% of people who get it, only very gradually get better, look forward to a lifetime of relapses and emergency admissions to hospital. So there's a lot to play for. Mental health services are under pressure. People with schizophrenia and psychosis often report poor experiences of care. So what we've done over the past 4 or 5 years, luckily funded by the Medical Research Council, is start to do something which a lot of people are now doing, which is look towards one's mobile phone. Anyone in the room who doesn't have a mobile phone? Yeah, great, one person. You'll tell us your story afterwards. So you all know what a ubiquitous thing the mobile phone is. And when we set out on this idea back in 2009 now, just as the first edition of MAHSC was forming, we asked health professionals, well, what do you think in mental health? What do you think of the idea of using people's mobile phones, people with serious mental illness like schizophrenia, to help them manage their own illnesses, to help them have a better experience of care? And in contrast to the patients, the service users, who are all enthusiastic about this, a lot of health professionals saw a lot of problems. And I guess this is one issue that we were hearing about implementation science. One issue is that the mental health services and health services generally are like super tankers. Turning these things around even a little bit is enormously difficult. And things like mobile health, connected health, are potentially very disruptive little technologies. So what we've done essentially is simply build an app, a smartphone app, starting about 4 years ago, and really driven by 4 constituencies, if you like. First of all, are patients, service users. And if I've learned one thing in this over the past 4 years, it is that getting patient service users involved at the sharp end to drive all this is absolutely critical. There are also software engineers led by John Ainsworth in the Institute of Population Health, social scientists, Caroline Sanders, and colleagues, and people like me, clinicians, and people in the Mental Health Trust. So what have we done? Well, pretty simple, really, and it's about enabling one's smartphone, one's mobile phone, to at semi-random intervals during the day, give you a little set of personalised questions, which you spend 60 to 80 seconds filling out, 15 or so personalised questions. Those are then wirelessly uploaded, those responses in real time to a central server, and analysed and fed back to the individual. And I mentioned patient-driven, experience-driven design. So all this, over the past 4 years, has been driven by a series of focus groups and advisory groups led by patients with histories of psychosis and schizophrenia. And in a second, we'll see a little video giving you a flavour of that. But here are some of the comments, some good, some bad, from when we started off, what people used to say about this prospect of using your mobile phone to help you become more healthy. People talk about the negative aspects, how intrusive perhaps it could be in a public place, but also the positive aspects, so how this works, how community mental health care works, just to remind you, in case you don't know, people with long-term mental health problems like psychosis and schizophrenia are linked up with a care coordinator, usually with a nursing background, who becomes their advocate, who organises all their care, their medical care, their social care. And that person is in contact typically every 3, 4, 5 weeks with the service user. One issue clearly is that people don't remember how their symptoms fluctuate over time and find it difficult to give an account. We've now started embedding this in services. So in the Mental Health Trust, Mental Health and Social Care Trust here, it's now started to run in a clinical team, and also in London too, South London, Trust in South London. And the data that we collect from patients, from service users, are organised and summarised and streamed through into electronic case records. And the whole idea of this too is to help prevent adverse outcomes, typically relapse. So relapse usually means that the person has to be admitted as an emergency to an inpatient bed. There are only 40% as many inpatient beds as there were 15 years ago. This is a big issue. So preventing people experiencing a relapse is potentially very important. And we can do this, we think, by getting people's individualized so-called relapse signature, a pattern of symptoms, these psychotic symptoms that people get when they suffer from schizophrenia, voices, paranoid ideas, and getting early intervention set up in real time rather than responding to a situation that's too late. So this is how it works, just a little schema for you. Semi-random beep from your phone. You respond to the beep, takes about 60, 70 seconds just to fill out all the items, the key items that are important to you. Get a bit of feedback. You can share that with family and friends in terms of the data summary. And you can share that with your care coordinator, your health professional. And as I say, what we're doing now is building it into the mental health community teams in terms of threshold alerts. So if someone's symptoms become over a particular threshold, the team gets an alert, and then there's a set of clinical algorithms about what they do as a result of that. So that's about early intervention. So I'm just going to show you a little, hang on one second, little video. And if you think the sound quality on this is poor, then I'll send you Peter Noble's email address. I'd like to thank the 3 service users on this video, Dawn Perry, Neil Sinclair and Kate Lurie, who each have been to hell and back. And any one of these stories, if you heard them, would make you weep. But you're not going to hear their stories. You're going to hear a little bit about what they've done for a minute or two in terms of helping develop this software program.
I think it's been quite interesting. It's been good to meet some new people and feel like you're having your voice heard and you've got some impact input into what's being developed. It's been really good, yeah, I've enjoyed it.
So I think what we did was we decided that we'd make it personal in terms of photographs of favourite football teams or background colours and pets or family members. So when you looked at it, you felt positive and uplifted rather than thinking about feeling down or low.
Yeah. I think I mentioned about having the ability to put extra things on there, so we've got like a diary function, so you can just type things in as the days go by, things that maybe the questions are asking you to respond to, but things that you want to kind of add to it as well.
Yeah. And when you go to your appointment after you've been using this app, they will have all the information and the data, and you will have your diary to accompany it, and you'll be able to show them exactly why you had a positive day, maybe because you met up with some friends or went for coffee, or why you were feeling low, and maybe you forgot to take your medication or something like that. So it works hand in hand with with your clinical doctor or something like that.
Yeah. Oh yeah, we talked about extra functions, didn't we? And I was saying it'd be good to have numbers of helplines, websites, all the places people can go to if they're in need of any sort of support other than what's connected to the care coordinator. So that's been implemented as well, which is good.
Yeah. It's quite good because you can look over a month how you've been going and keep track of yourself. Try better the following month, I guess.
I found it quite beneficial because we've got a mental illness, and some of the questions were like asking how are you feeling, which I'm having a bad day. I was feeling depressed or anxious, just slightly. So it was like keeping tabs on me in one aspect.
Yeah.
Like just checking up really.
And what do you do if you're in the middle of something where you don't want to be disturbed?
Well, you can soothe it for 5 minutes.
Great. And did that work all
That
right?
works okay,
And then usually by the time the 5 minutes...
Yeah, I can go back to the question.
Yeah.
I enjoyed it when we actually got to see the app properly on the phone for the first time. I really enjoyed that meeting because it come to fruition and you could really see and literally hold in your hand what you'd helped to...
Brilliant.
Sorry about the sound quality, but I think you get the idea. And so there were 3 of the service users, the patients who helped us. So it's been a very collaborative process within MAHSC, and MAHSC has proved to be very important as a vehicle to get this collaborative research delivered, and continues to be so. We think we have 4 impacts now. We've just halfway through the 5th randomized controlled trial funded by the MRC to look at this. We've got improved user experience of care, a better user health management. You saw from the little graph that gives you an idea of how your symptoms fluctuate. Schizophrenia and psychosis is multifactorial disorder, about 100 risk genes we know, but also a series of psychosocial factors which act in conjunction with genes to give you the symptoms. Getting people to manage their own health better appears to be critical here. Early intervention and prevention, a little bit about the Care Loop program, which is currently being evaluated, and we have a sort of platform to deliver some future research here too. So to finish off, thanks to MAHSC, we've managed to construct this little project. It seems to be quite successful. We've got it integrated into community teams in Manchester, in the Mental Health Trust here, and in the South London and Maudsley Trust in South London. We've got demonstrated projects using ClinTouch in 5 other NHS trusts. The project manager for this is Charlotte Stockton, who's worked very hard. The latest is St George's, so again, a sort of MAHSC product is being rolled out, we hope, around the country. We've got a legally binding partnership agreement with the NHS Confederation, between the Confederation and MAHSC, and we came second. God, it was so close in last month's Bio Healthcare Innovation Awards. So, and I think that's it. So that's the team. So I'd like to thank Michelle and MAHSC and everyone else who's involved, and I hope that was interesting.
Thank you very much. Thanks very much indeed. Michelle, come and join us, because I was really, well, firstly, I like the name, ClinTouch. Who would have thought? And it's a brilliant name for a phone app. But actually the implications of the technology, that approach, go well beyond the treatment of perhaps more acute elements of mental health. And I was wondering about, whether you could use it, in terms of, mild to moderate anxiety and depression that people could relate. Perhaps if they're involved in psychological therapies, you could even have computerized CBT on the mobile phone. I mean, tell us, the sort of potential of what you're doing there.
Quite right, Mark. So it's clearly applicable to any long-term physical or mental disorder. And what we've really, how we started this, I guess, was saying to ourselves, well, if we can make this work with people with serious mental illness, surely it can work in any population of people with a health problem. So you've got a platform technology, basically, which can be applied to long-term physical conditions like diabetes, cardiovascular disease, as well as you say, other long-term mental health conditions. So we're now developing, as you say, Sandra Bucci, one of our clinical psychology colleagues, has herself now got an MRC grant to develop a cognitive therapy platform within this. So it is...
How difficult is it to do? I mean, it's great to have it there, but the difficult bit, I'm going to guess, is you had your picture there of the team receiving the information. As soon as you have a team bit, or even a sort of personal carer bit, they have to be supported. The information has to be secure. Very often, if you're dealing with confidential records, suddenly, well, perhaps Michelle. I mean, this is actually quite a difficult thing. Well, tell me, has it proved easier or more difficult than you anticipated in terms of trying to make the system work so that people's records are secure, but the information gets to the right people and they can take action? That seemed to be so important.
I think it's like anything. It's always it's always easier to map it on paper. Then when you start working with teams, it becomes really difficult. So they have had some obstacles to overcome, but now it's really been sort of utilised and rolled out. Then we've overcome a lot of that. Some of the first information that I'm getting from the teams is it actually helps plan out and map people's days when they come back to clinic, for example. The information's there, which they wouldn't have, and they won't have it in the graphical form. You saw the graph up there as well. So you get that total side, whereas people sometimes forget the really bad days.
Yep.
Or they remember the really bad days, but sometimes forget the really good days. So I think it gives them that really mass perspective across the patch. Would you agree with that, Shon?
Absolutely. The only downside, Mark, is that every NHS trust has its own ICT system.
Yep.
And so there's no one-size-fits-all approach to that. So if you're going to try and embed this into a secondary healthcare trust, acute trust or mental health trust, it's quite a lot of work and you've got to start from scratch each time.
And perhaps something that MAHSC could work on as a project, just to sort of, because as I say, obviously it works, it seems to be working terrifically well with that particular aspect of mental health, but perhaps right across this room, people, mothers expecting babies, just keep in touch, a way of just informing them of little things that are happening. Do I need to take further action? Any kind of chronic health problem, obviously.
Yeah, that's right. So one of the things we've done is to make sure it's safe. So people assume these things are safe. That's not an automatic assumption, and some people with mental health problems actually find it quite distressing. So it's not everyone's cup of tea, but over 70% of the people we asked to try it out think it's good.
Not everyone has a mobile phone, we have to remember that too.
But more people than you think, and people with mental health problems actually are more dependent on their mobile phones than you or me, because they're so socially isolated often. So their mobile phone is actually quite a potent platform.
Terrific intervention. Thank you very much indeed to Michelle Moran and Shon. Thanks very much.